Wednesday, May 13th, and this is our TASC 90 webinar. So we are here today to talk about the coronavirus and COVID updates and Flex program support. Today we have Tori from the Federal Office of Rural Health Policy, Carrie Cornejo from the Federal Office of Rural Health Policy, Aaron Reinhart from the American Ambulance Association, Sarah Brinkman from Stratus Health, Megan Lahr from the University of Minnesota and the Flex Monitoring Team, Nathan Bao from Rural Health Clinic, or from National Association of Rural Health Clinics. We have Terrell Eisinger from the National Organization of State Offices of Rural Health. We have John Supplett and Maggie Elawani from the Hospital Association and the National Rural Health Association, respectively, for updates related to updates and policies related to COVID-19. We'll open it up to hear from state flex programs on what they're doing, any changes they've made to their work plan, questions, issues, things like that, and then I've got just a couple updates from the TASC team to close it out. So we will get started with Tori. Are you there for our updates from the federal office?
Hi everyone, can you hear me?
We can. Welcome. Thank you.
Wonderful. Thank you so much for being with us today, Flex coordinators. So I just have a few updates for you. The first and foremost is that your NCC is due to EHB this Friday on May 15th. If you are opting to submit a request for information, please submit that in your performance narrative section, and then make sure you complete all of the necessary tabs for the NCC submission. Just a reminder that Natalia and I are willing to assist any Flex program willing to adjust their FY19 work plan to incorporate COVID-19 activities. Please set up a time to discuss these changes with either Natalia or myself, whoever is your acting project officer. We are announcing a new division within the Federal Office of Rural Health Policy. The Rural Strategic Initiatives Division will serve as a focal point within FRHP to plan and coordinate new rural program initiatives created as a result of agency, department, or administrative priorities. Specifically, they'll be working on the Rural Health Substance Abuse Grant Program, which we call RCORE. They will lead and manage new rural health program initiatives that emerge as a result of the agency, department, or administrative priorities. They will provide technical assistance to grantees in rural communities, and they will evaluate new rural health programs to determine the impact of the resources invested in rural. We also wanted to inquire to you all about the Provider Relief Fund. On May 1st, HHS began the distribution of payments to hospitals with high COVID admissions and rural providers. If you are receiving any questions from your stakeholders about the Provider Relief Fund, please shoot me an email. We are collecting any questions that are coming out from our stakeholders. I can't promise any solid responses just yet, but we are in the process of collecting those questions. And then I just wanted to also share with you all that we are actively backfilling the 2 Flex positions, so we hope to have 2 new Flex POs on board very soon. Thank you so much for all the work that you guys are doing.
Is that all of your updates, Tori?
Yep, back to you, Caleb.
Thank you. So Catherine had one question. If you could go over that again. If we put in for the delay, we still have to submit something on Friday.
Catherine, you already submitted that request. So as long as the NCC task is no longer in your EHB queue, you are all set.
Great. Thank you for that clarification. All right, Carrie Cornejo, are you on? *2 will unmute your line.
just unmuted myself. Can you hear me now?
There you are. I can.
Okay.
Welcome.
Okay, great. Thank you. Hi, everyone. I'm just going to provide a few brief regulatory and policy updates today. I know John and Maggie are covering COVID-related updates, so I don't want to take away from their presentations. And then we have Nathan on RHCs and Terrell on the NoSOR updates. So first, I just wanted to start with the latest, which was the release of the IPPS Inpatient Prospective Payment System proposed rule. Comments are due July 10th, and I think the biggest item of relevance for rural hospitals and CAUS is that CMS has not made any proposals to update the hospital star ratings. They had indicated that they would do so in the rulemaking for FY fiscal year 2021, but they decided to change their plans in light of the COVID pandemic and not wanting to add any burdens associated with changes at this time. But CMS did indicate that they're planning to revisit the star ratings topic in future rulemaking. So when they say future rulemaking, I expect that would be fiscal year 2022 at the earliest. So more to come on that. So it's right in the proposed stage, and CMS is accepting comments. Since we're on the topic of policy delays due to COVID, I just want to note some recent updates around deadlines for interoperability requirements. Both CMS and ONC are delaying enforcement of the new interoperability rules published earlier this year, and CMS is delaying enforcement by 6 months, while ONC is delaying by 3. CMS also noted that they'll be extending the hardship exception application for the promoting interoperability requirements for hospitals to September 1st, which was previously July 1st. But for CAUS, the deadline to submit a hardship exception application is a little longer. It's November 30th. Similarly, CMS announced relief for clinicians, providers, hospitals, and other facilities to participate in a number of their quality reporting programs, and this has also been in response to COVID-19. I just really briefly, I would mention that on April 30th, CMS issued their second round of second interim final rule in relation to COVID-19, and these changes build on some of the temporary regulatory waivers and new rules that CMS will now expect on March 30th and April 10th. Highlights of the waivers and rule changes in this round include flexibilities to increase hospital capacity, healthcare workforce changes, efforts to reduce administrative burden, and then a number of expansions of telehealth and Medicare. But more information on this waiver and guidance, you can find that either from the interim final rule, and CMS also has its own COVID-19 flexibilities webpage. Again, quickly, CMS recently published its final notice of benefit and payment parameters rule for the 2021 benefit year. This is for the marketplace for health insurance plans. There's not a lot in there I'd say that's going to be specifically relevant in a rural context. Federal interest, though, CMS has included several provisions intended to promote affordable health care coverage, including a blueprint for issuers to design innovative healthcare plans. So new benefits under these new designs might include an issuer, for example, offering a plan that provides services like blood pressure monitoring or cardiac rehabilitation with zero cost sharing. And the rule also makes it easier for individual market issuers to offer wellness incentives to their enrollees. Something relevant for hospitals as well, and it came up in the past couple of months, and I want to make sure you are aware, CMS issued a memo that conveys information in response to inquiries from hospitals and CAUS concerning implications of COVID-19 and their EMTALA compliance. So the memo was revised to include additional guidance related to the establishment of drive-through testing sites, clarification of expectations in relation to the triage process and medical screening examinations, and the use of telehealth. And among other topics, the memo addresses transfers to and from rural hospitals. On the RHC and FQHC side, I won't spend too much time covering this since I know we have Nathan on the line, but CMS recently put out guidance between the COVID-19 flexibility for RHCs and FQHCs. I think of particular interest will be the guidance about the telehealth distance site billing for RHCs and FQHCs, which is something new that they haven't been able to do before in Medicare. Outside of HHS, I just note that the Small Business Administration recently published an interim final rule with additional guidance on implementing the Paycheck Protection Program. So on the topic of healthcare, the rule clarifies that hospitals owned by government entities could be eligible for a PPP loan if they meet the other eligibility criteria and if the hospital receives less than 50% of its funding for state or local government sources, exclusive of Medicaid. And also, I'd note that the RHI Hub has a page dedicated to information on the Small Business Administration's coronavirus relief programs. And just to wrap up with an update on CARES Act funding from HHS, you might have heard that CMS recently announced that it's reevaluating the amounts paid to providers and medical suppliers under its accelerated payment program and suspending its advanced payment program. CMS had expanded these temporary loan programs in the beginning stages of the COVID-19 emergency, but they noted that HHS continues to make funds available to hospitals and other healthcare providers on the front lines of the response, particularly from the CARES Act provider relief funds and those that were announced back on April 22nd, including the $10 billion allocation for rural providers that Tori mentioned. And you can also find all these updates along with the links to the relevant resources on the policy page of the Federal Office of Rural Health Policy's website.
Great, thank you, Carrie. Any questions for Tori or Carrie? Not hearing none, we'll go to Aaron Reinhardt from the American Ambulance Association. Thank you for joining us, Aaron. You have some EMS updates for us? You're still muted, star 2.
How about now?
There we go.
Oh, such wonderful technology. So thanks for inviting me today, and I'll spend just a couple of minutes talking about things that are specific to emergency medical services in COVID-19. So first and foremost, there's really 4 points that I wanted to emphasize. First, cost reporting, the collection of costs that ambulance services, 1/4 of them each year for the next 4 years, will have to do, has not been delayed by CMS. All indications is that they will expect ambulance services that were selected during this first round to submit their cost based on whatever the particular calendar year is that they're using. So fiscal calendar year, if it's January to December, would mean that they would be reporting in the first part of 2021. If it's September or October or July or June, that kind of fiscal year, it would be in the mid of 2021. So flex programs, to the best of your ability, if I might humbly ask, to make sure that ambulance services that were selected realize that there has not been any waiver or pause of that program. CMMI, the Center for Medicare and Medicaid Innovation, has paused the ETC project, and there are other waivers CMS has put out, but cost reporting has not changed. There are lots of resources available for emergency medical services during COVID-19, some good, some not. So often folks are recommending that CDC be the single source of truth for all things clinical, personal protective equipment use, reuse, exposure, et cetera, as well as EMS.gov to be another single source of truth for reference material. There is a Federal Healthcare Resiliency Task Force that meets on a daily basis, and they have 3 work groups, pre-hospital, hospital, and out-of-hospital work group. I'm part of the pre-hospital work group with many of the federal agencies you would expect to be involved, and they have published, I think, close to 40 documents that provide reference information, best practices for emergency medical services to consider. A number of CMS issues, such as the previous presenter was talking about. CMS did provide a loan program where you could receive an advance on your payments from using the last 3 months as kind of the amount. They would forward you 3 months worth of payments that you would then begin to pay back around the November timeframe by deducting it from payments you had coming in. They did close that program to emergency medical services based on the number of people who had applied to it. There may be the opportunity for that to be opened back up again to ambulance services as a resource. CMS has provided several waivers. The first is the ability to bill for transportation to a location other than a hospital. So today, ambulance services can only bill when they transport to a hospital. Under this waiver, going back to the beginning of March, ambulance services could bill for transportation to a location other than a hospital, such as an alternate care center, a facility specifically stood up for the treatment of a COVID-19 patient. CMS did provide, as part of the CARES Act, some additional funding to ambulance services. It was about 8% of what they were reimbursed by, not what they billed, but what they were reimbursed by CMS in 2019. My ambulance service, in addition to being the president of the AAA, I run an ambulance service that serves rural parts of Minnesota and Wisconsin. We received out of about $7 million worth of gross charges. We received, I think, about $56,000 from CMS. So not significant, but certainly not insignificant. Ambulance services who accepted those funds within 30 days has to sign an attestation that they will not balance bill non-CMS patients. So we've never been able to balance bill CMS since the Balanced Budget Act of 1997, but this would require ambulance services to not balance bill non-CMS patients, so like private payers, Blue Cross Blue Shield, Medica, depending on where you're from, Anthem, Health Partners if you're here in the Midwest, UHC, et cetera, et cetera. So that's something they may not know. Many ambulance services have chosen not to accept those funds because the cost of accepting assignment to those other payers sometimes is larger. I see a great head nod from someone, so thank you. I know we did the math, and it was a tough decision in my own organization. So, and then there's also some waivers from CMS around signatures. Normally, ambulance services have to get a signature from the patient, the beneficiary, for the ability to bill on their behalf. CMS has acknowledged during COVID-19, changing pens with each other and things like that may not necessarily be the wisest of things, and so they've just reiterated that ambulance providers are expected to make a good faith effort, similar to the PCS forms, the physician certification statements that are needed for some interfacility transfers. They've said similarly if you make a good faith effort. So a number of different resources out there. There is a PPP loan, Payroll Protection Program loan, you've likely heard about, through the Small Business Administration. That program did close based on the use of it. Congress is certainly talking about in Stimulus 3.5 and Stimulus 4 that was announced, the House version yesterday, potentially refunding that program. It does come with a number of very technical caveats, and so I would really encourage ambulance providers who may have gotten the PPP loan to really understand the obligations. There's no guarantees it will be forgiven, though that's our understanding, but it can only be used for very specific things. Repayments, it's only meant for 2.5 months, which means about June 11th, and payments start in November. So happy to be a resource to folks that may have some questions about that. Looking at my time, because I'm really bad with time, those that know me, Caleb smiled, so that's good. I'm watching too. Those that know me know I can barely say my name in less than the 15 minutes, let alone give a presentation. So I'm trying. I've got my notes. I'm trying to follow them. My last 2 points, and I know I'm preaching to the choir on this, emergency medical services were largely missed in all of the stimulus bills to date. While there is $100 billion in the CARES Act for healthcare, certainly those dollars were meant to serve all of healthcare, to meet the hospital needs, which it certainly doesn't, to meet long-term care facilities needs, which it certainly doesn't, to meet ambulance needs, which it certainly doesn't, and the list goes on and on and on. So today, ambulance services are very fragile, if not collapsing. I know of several organizations nationally that have closed their doors. I know of ambulance services, especially rural and remote, often staffed with volunteers that are unable to respond. And so I would just really implore all of you that have the ability to, I won't say lobby, but to advocate. It's critically important that we get the word out there to the federal government, FEMA, Health and Human Services, Homeland Security, that ambulance services have largely been overlooked. And by no means am I trying to say that hospitals have not also, and other aspects as well. So ambulance services all across the nation, like our partners, are critically short of PPE, surgical masks, N95 masks, the list goes on. Many of them have less than 30 days worth of cash on hand to pay their bills, to pay their workforce. Many are having inability to find and keep the staff. So one of the examples I'm hearing, especially in the Intermountain states, is that the volunteer staff are being told by their full-time employers that while they respect them, they deeply love them, they honor the commitment they're making to their communities by staffing that rural ambulance service, that if they go on ambulance calls, they can't come to work. And it's not because these people are horrible, terrible people. It's because of recognition that that volunteer could potentially bring into the school district or the Kubota plant or the Bobcat factory, or the list goes on, COVID-19, and of course the incredible impact that could have on that particular business. So I would just really emphasize, and I think again, I know I'm preaching to the choir here. I see folks that I've known for the longest time, like Catherine Miller in Wisconsin and many others, who know and regularly work every day to help the long-term sustainability, viability, and reliability of our nation's emergency medical services, that COVID-19 is pushing them to collapse. They're without the funds that they need. They're having a hard time finding and keeping the workforce. They're losing staff to COVID-19. I think you all know we've had deaths all throughout the healthcare system because of COVID-19, and the ability to have new workers come in is really limited because classes are closed, EMT classes aren't happening, people can't test the practical exams. So I would just really end my comments. I shall note 3 minutes early, Caleb, with imploring all of you to keep up the excellent work that you're doing, and if you could, and you have the ability to do so, to really advocate for emergency medical services, ambulance services, as part of the national response. And I guess I will take back 2 of my minutes. Treat in place is a common practice. Caleb's thinking like he can stop me, right? Is a common practice where ambulance services all across the nation are responding to ambulance requests for services and recognizing that somebody has COVID-like symptoms, but also the recognition that transporting them in, if they're medically stable, doesn't provide anything. If anything, it just overwhelms the hospitals. And so they don't transport them today. Instead, they treat them in place and regularly check up on them. That is not reimbursable by Medicare. Medicare has flatly said it is a transportation benefit. And Medicare is the single largest payer for the nation's ambulance services, and in many cases is 70% of their revenue. So by doing the right thing, in this case not transporting a patient, they're punishing themselves and putting themselves into financial jeopardy. And so it's the recognition, I think we've all understood, that the system today of only funding ambulances when they're transport doesn't make any sense. And so it's really coming home in how it's affecting ambulance services, especially non-governmentals, private non-for-profits, hospital-based, and private for-profit. So I yield back.
Great. Thank you, sir. Thank you again for joining us. Do we have any questions for Aaron from the American Ambulance Association EMS update? Star 2 will unmute your line. All right, hearing none. Oh, maybe in the chat box. Hold on a second. What can the Flex program do to support EMS in rural communities? Anything quick, Aaron?
Yeah, I would send them to CDC website for clinical and operational information, ems.gov for best practices. Get out the information to them about what financial resources might be available, but continue to be their advocate within state government, federal government, and with Congress as appropriate to make sure that they know that when they pass the stimulus packages, they have not fully taken care of all of the needs of local ambulance services.
Great. Thank you, Aaron. Thank you. We have one additional question. What is the current state on stat on percent of EMS providers who are volunteer, and then how many states have fully paid systems?
Yeah, so it continues to be about 80% of the nation's ambulance services do about 650 calls a year or less, and often those services have some mix of paid and volunteer. However, conversely, 20% or what am I trying to say here? 80% of the nation's calls are done by 20% of the services, who are also often large services like AMR, Acadian, Paramedics Plus, such. So our volume continues to be done primarily by full-time paid services. However, most areas are still covered by small services that are often still staffed with some mix of volunteers.
Great. Thank you, Aaron. Thank you for your update and some resources. We will be compiling the minutes or the notes from this call and sending that out with the recording stuff too, because I know there's going to be a lot of dates and a lot of mentions on things like that we don't have links to send to. Sarah from Arcata, you have updates for us.
I do. Hi, everybody. So I should be able to do this in 5 minutes and just have a few kind of reminder updates. So you should have all received an email from Christy Martinson on May 5th announcing that F4HP is extending the deadline for state flex programs for submitting their Q1 2020 EDTC data until May 29th. We want to make sure to remind you all that you should be using the pre-populated state-specific template that you received from F4HP via NIH. If you don't have that, you can let us know or let Natalia or email mbquip@hrsa.gov to make sure that you're able to get that. If you have any questions about that deadline, please let us know. And then Natalia Vargas had sent out an email back on March 25th announcing that recognizing the strain of the COVID-19 pandemic on hospitals and in alignment with CMS reporting updates, that critical access hospital MBQIP data submission will be optional for Q4 2019, Q1 2020, and Q2 2020. So the MBQIP submission deadlines chart and the recent MBQIP reporting reminders that we've sent out have been updated to reflect these exceptions. Critical access hospitals that have the capacity to report are strongly encouraged to continue to do so, and if you want help with that messaging, the Arcata team's happy to talk to you about that. We have received a number of questions since that announcement was made about deadline extensions, and just to clarify at this time, there are no deadline extensions for CAW reporting. This is an exception. So if they are able to report, they need to continue to report with the deadlines that currently exist. On a more exciting front, you might remember that last September, following a call for nominations and an application process, Stratus Health selected 8 experienced critical access hospital staff to serve as national virtual quality improvement mentors through a new program. And our goal there is to broadly transfer knowledge from leading critical access hospital quality improvement staff to others across the country. And as part of that program, our QI mentors come together periodically to share what we're calling PI, and that stands for Performance Improvement Experience. And through short recorded conversations, they discuss key topics that help drive quality improvement in their rural hospitals. So we're really excited to announce the availability of the first installment of Quality Time Sharing Pie, where you and your quality improvement staff and others can hear mentors' lessons learned, strategies, tips, and ideas. Included with each episode that we release will be supportive resources for each topic, along with mentors' favorite real pie recipes. This is kind of fun. We're aiming for the conversations to be 15 minutes or less in length, so they're very accessible, and we plan to release them quarterly on our QI Mentor webpage and promote them through MDQuip Monthly. You can also subscribe to them as a podcast through whatever your favorite streaming service is. So we hope you'll check that out and share it with your hospitals. A couple last things. We recognize that the previously scheduled June MDQuip Virtual Knowledge Group is now slated to conflict with the virtual NRHA annual conference, and we're in discussions with F4HP about that event. If we do end up holding an event in June, it will be rescheduled, so watch for an email with more information. And finally, our MDQuip talking points, which highlight some key messaging for sharing with hospitals about the importance of them participating in the program, is undergoing final review after a round of updates, and we expect that that should be available within the next week. And that's all I have today.
Great, thank you very much, Sarah. Any questions for Sarah? We have one question in the chat box that said, did you mention something that had no deadline exception?
So there are no deadline extensions. If hospitals are going to be reporting their data, they need to report it by the same time that they would have otherwise. There are reporting exceptions. The only extension to mention at this time is that you all as state flex programs have an extension for getting the EDTC data into F4HP. There was not a change in the deadline for the hospitals to get that data to you. So if, particularly for those other measures, the CMS measures and the NHSN measures, they need to be submitting on the same timeline that they would usually if they plan to report. And we strongly encourage that those hospitals that have the capacity to report continue to do so.
Thank you very much. Any other questions for Sarah and our ARPITA team? Hearing none, I will thank Sarah and go to Megan Lahr from the University of Minnesota and the Flex Monitoring Team. Are you there, Megan? Star 2. We'll unmute your line.
Yes, I'm here. So hi, everyone. We have just a few quick updates from the FMT. In the past couple of months, we've released several new products. In March, we started with our annual quality reports, focusing on hospital compare data. That included a national report as well as 45 state reports. And our community impact report should be out within the next month on the similar scale of national and state reports. We've also updated the financial and quality data in our Compass data query tool to include 2018 data. Right now that's just for financial and quality, but we're in the process of updating the community data as well. And there are a few other products, two that are related to financial and operational improvement in CAUSE, one that's on best practices from CAU executives, and another that's on CAU Medicaid payer mix in expansion versus non-expansion states. And we also have a summary that kind of explores state data sources to monitor rural EMS performance improvement. Along with those recent products, we're continuing to work on projects for this year, including a few that we've been in touch or will be in touch with state flex coordinators about. Some of these are focused on evaluating the use of CAU cohorts for quality improvement activities, as well as assessing CAU community engagement. We are also nearing the completion of a redesign of our Flex Monitoring Team website, so keep your eye out for that early this summer. And we're also looking ahead to our proposed project for our next project year, which begins for us on July 1st. Some of the projects we're looking to do are focused on identifying potential new measures for MDQuip, evaluating EMS supplemental grants, examining the effect of system affiliation on CAU financial performance, reviewing lessons learned from state and federal demonstrations and initiatives to support rural hospitals, as well as assessing strategic responses to COVID-19 and CAUSE. And so that's all that I have.
Great. Thank you very much, Megan. Any questions for the Flex Monitoring team or Megan?
Megan, this is Carol. When do you think you'll have your lessons learned from the demonstration report, I think you said? Yeah, so that's actually a project that's just beginning in July of this year. And so that probably won't be until next spring, I would say. Thank you. No problem.
All right. Thank you very much, Megan and the Flex Monitoring team. Next, we have Nathan Bao from the National Association of Rural Health Clinics. Star 2 will unmute your line, Nathan.
Hello, everyone. My name is Nathan Baugh. I work with the National Association of Rural Health Clinics. Thank you for having me on this call. I'm going to talk about some rural health clinic specific issues, but this is my first time talking to this audience in particular, which I assume is the Flex coordinators. Is that the best way to say it, Caleb?
It is, yes.
Okay, so this is my first time talking to the Flex coordinators. Usually I talk with folks that are like office managers that are running rural health clinics and things like that. So hopefully we can match up my understanding with your understanding and it's useful. Just very briefly, I'm going to talk about really just three things. We've had a lot of telehealth changes for rural health clinics as a result of COVID-19. And I'll go through those briefly, but it is more nuanced than what I'm going to get into here. Then we're going to talk a little bit about the Provider Relief Fund. I know Carrie mentioned that at the start of the call, and talk about what's to come in regards to the Provider Relief Fund and what to look out for. So for telehealth and Medicare policy, there have been just a dizzying amount of changes in the last 3 months for rural health clinics and for really all outpatient care. I'm going to spare you guys all the history and the timeline and just talk about the current policy, which is that rural health clinics and federally qualified health centers are allowed to provide distance site services, but we provide distance site telehealth services different than everyone, all the fee-for-service offices provide. We, instead of billing one of the many different CPT codes, I think there's over 200 that Medicare has approved as a service that physicians can provide through telehealth. Instead of doing that, we bill this one code, G2025, for all of those. And that code is going to pay $92.03. Complicating things is the fact that between now and June 30th, rural health clinics and FQHCs will get paid their normal rates, which are generally going to be higher than $92.03. But then in July, they're going to actually have to owe that money back to Medicare. So there's going to be a recoupment period in July that we'll have to deal with. Now, for some rural health clinics, the independent rural health clinics and the rural health clinics that are subject to a cap, this $92.03 is actually better than their normal in-person rate. So they'll actually get a bonus, and it's going to be, the difference between your rates and $92.03 times the number of telehealth visits you billed up until June 30th. So we have a convoluted system. There's a lot of flaws with it, in my opinion, and we are working and advocating for a better fix to this, such that we bill the normal CPT codes, we get paid as if they were in-person visits, just like our fee-for-service peers get paid. So that's the long-term trajectory we would like to see this telehealth policy go on. One big thing that I would note, and just in case you're not aware, one nice thing that CMS did do 2 weeks ago in an interim final rule is that they did say that audio-only services are allowed to be billed as this G2025 service in a rural health clinic. So I know that in a lot of rural areas, we might have broadband issues, et cetera, or even just Medicare beneficiaries who aren't necessarily going to be able to use an audio-visual app. So for those folks that can only call, you can have them talk to the provider, and that is now, as of April 30th, considered a telehealth visit and billable as G2025. That's not a nuanced statement. There's a lot of nuances there that I don't have time to get into, but in general, we were really happy to see that particular change. So moving on from telehealth, just want to talk briefly about the Rural Provider Relief Fund. Actually, one last thing on telehealth, and I should have put this in there, but I wasn't sure if this was a place that you could advocate for things. But considering the ambulance gentleman's pitch, I figured I should make my pitch as well. The legislation that would fix this is called the Improving Telehealth for Underserved Communities Act. Improving Telehealth for Underserved Communities Act. And that's the solution that we're hoping to get passed before July, so we don't have to owe all this money back to Medicare. All right. Moving on to the Rural Provider Relief Fund in the context of rural health clinics. Most rural health clinics, not all, unfortunately, there are some categories that didn't get money, but most rural health clinics did get money last week. Provider-based rural health clinics received money through the hospital's payment. I presume most of you guys already know that. Independent rural health clinics received their money directly. The minimum was $103,000 plus I think it's like 3.6% of the rural health clinic's operating expenses from 2018 was the amount that the independent rural health clinics received. For independent rural health clinics that filed joint cost reports or consolidated cost reports, those payments may have been made just to one entity that they would have to then sort of distribute amongst the various independent RHCs that filed together. And of course, if the money was paid to the hospital, it is a system decision how to distribute some of that money within their different facilities in that system. Now, this Rural Provider Relief Fund was different and separate from the general allocation made in early April. So I just want to make this clear that this money is in addition to the funds that folks received in early April, and that general allocation should have been roughly 2% of your 2018 net patient revenue. And it was made in two tranches, and again, I don't want to get into all of that, but the point is that the rural facilities got their own separate pot of money last week. There are some generally folks that don't have an electronic billing relationship with Medicare that didn't get any money, but are getting checks in the mail that should arrive sometime this week. So if you know of pediatric RHCs, for example, that may not have gotten any money, there's a strong possibility that their check is simply in the mail and that they would get it this week. So if you hear of RHCs that absolutely should qualify and for whatever reason did not get money, please pass those along to me. There are a number of sort of caveats and carve-out situations that for X, Y, and Z reason, CMS didn't have them, or HHS didn't have them in the database. So we're trying to troubleshoot those issues as they come. And then this is my last slide, and that's really just to alert you that there's going to be more things coming. There's $225 million that HHS and HRSA have to distribute to RHCs. That's going to be a little bit more linked to COVID-19 testing than some of the provider relief funds. The details are really being worked out, but that, if you do the math, that should be roughly $50,000 per RHC. I do not necessarily think that that's going to be varied by operating expenses, so I do think that that's going to be sort of a flat payment to all RHCs. And again, that money is going to be expected that you use it in some form or fashion related to testing, but the details are still being worked on and should be released hopefully in a week or two. So stay tuned for that. And of course, I think everyone knows that the Provider Relief Fund still has, almost $100 billion left in it. And so there will be more allocations, I expect, and it will get more complicated, but more money hopefully is on the way to providers who need it. All right. Finish with 4 minutes.
Very much. Right. Do we have any questions for Nathan? RHC clinic related? *2 will unmute your line. All right, we have one person typing, Nathan. We'll hold you just for a second for that. Really helpful to have RHC updates. Thank you, Leah. Good to know.
Kayla?
Yeah, well, thank you very much. Oh, yeah, go ahead.
Kayla, this is Lisa Davis. I just sent an email to Nathan, but this might be of interest to others as well. Nathan, would you mind providing the text of the bill that you talked about, the telehealth bill?
Yeah, I'm happy to provide it. If you Google it right now, the GPO hasn't published the text yet, but we have that text, and it is on our webpage, narhc.org. So I can email you directly, but because I have your email. But for other folks that maybe don't have my email, if you go to our website, it should be the first thing you see, and there is a downloadable file to see the full text. But in about a week, it'll be posted on congress.gov, and yes, it's narhc.org.
Excellent. Thank you.
Thank you very much. All right, next up is Carol Eisinger from the National Organization for State Offices of Rural Health. They have a bunch of stuff going on, but one of the specific things is the weekly calls that you guys have been having. Carol, are you there?
Yep, I'm here. Can you hear me okay?
We can. Thank you and welcome.
Great. So I was asked to just give a little overview of these weekly calls and the results of them and lessons learned. And the timing is perfect because we're about 6 weeks into doing this. We love doing them. We love that it gives us a connection to all of you and to the other staff of the state offices of rural health. It's a little odd for me to give you an update because I'm kind of on here telling you what you already told me. Every week on Thursdays at 3 p.m. Eastern, we meet, and Chris Salyers and Tammy Norville work together to listen to you and to provide you updates on the regulation. Chris does a really great job of facilitating the calls and taking notes and jogging people who have samples of work to share and getting questions answered. And Tammy is really dialed in to checking exactly what the regulations say, making sure you're getting the straight skinny and following up and keeping us updated as best we can. So those calls have a pretty regular agenda. You can see it there in front of you. with just an update on resources, strategies, needed resources, concerns on federal programs, and then we're always open to posting and posing and discussion questions from national partners and others that you're interested in hearing about, so I invite you to do that. And we post them on the website weekly, which are almost verbatim transcripts of what we talk about on those calls. So what I'm going to, the calls are fascinating. For one thing, I have a new appreciation because I know so many of the state offices of rural health and the FLEX programs are working so hard. You know, we hear about people working in all the call centers for their states. We hear about people crunching the data and doing some of the real monitoring and tracking about what is happening across their state. So we know that this is a very stressful time, and we so appreciate that. We still get about 60 or 70 of you on every single call, and we're so appreciative of that, and that you give us your time and your expertise. The topics have been all over the place, and there's a little list of them. I'm not going to touch base on all of them, but what I've tried to do today is it's also been fascinating to kind of look at how the topics have changed, and our interests and our worries and our resources and our innovations have changed over time. So just in 6 weeks, things are really, really moving fast. So what I want to try to do today is kind of give you some trends and some issues out of what I've been hearing and what I've seen from what you're doing. I hope you know me well enough to know now that we always focus, this slide is about the potpourri for the power of rural. We always talk about collaborate, communicate, and innovate. And this is kind of a catch-all slide to sort of show you the breadth of the kinds of innovative strategies and things that we're seeing and observing and hearing from all of you. The things that I present today are strictly from the transcripts of the calls. And I think it's just so fascinating to see this breadth of work that is happening as a result of FLEX program investments, but also with the engagement of rural communities and other places, and the things that you're hearing about and bringing it to us. I'm so impressed by the work, and I think there's some real opportunities to continue the work with foundations, to leveraging partnerships to raise funds and make grants to community organizations. That's a great strategy and something we want to grow more of. Also, we've heard about state offices of rural health that are doing briefings for their governors that, you know, we're just little rural health facts that turned into a rural town hall meeting where the governor paid attention to all things rural issues, that turned into official public health official briefs, that turned into a targeted newsletter, that turned into a state epidemiologist blogging. So you can see that when you look through that sort of compendium of community engagement and other state office of rural health engagement, it's just fascinating. I love the engagement with the faith-based organizations, and Lisa's on the line. The work that she's done with Anabaptist is just a great example of engagement with the faith community, everything from posters and media to hearing and promoting drive-up buggy testing. So I think that's fascinating. So I'm just going to kind of slide through these, and also to share with you that as we look back about what you've told us over the last 6 weeks, those resources, certainly if you can point us to other things that you need, we can work in partnership with the great national partners who are on this call. But, you know, you see more needs for EMS, first responders, and other essential workers, and a real need for state coordination, and maybe even some resources and tools about that. So the rest of the slides aren't so potpourri. They are sort of general themes of concerns and challenges and resources. And I did try to focus on the strategies that are positive, the things that we can learn by seeing what are some effective methods of innovation and what is working that state offices are reporting. So around primary care provider needs is one cluster. When you look back over the last 6 weeks, it really isn't just about hospitals. All of you on this call know that. You know about the importance of addressing the primary care landscape. You know that they need to be robust primary care providers. But I also think it's fascinating to kind of look at the work that we're seeing done. The survey of RHCs that's done specifically around PPE, collection and testing work with systems, working with systems to bring in more resources for rural health clinics. That's fascinating. And also I thought it was a heads up looking at strategies for some, for concern by some clinics who are hearing and getting patients and referrals from sort of like community testing events, but then aren't so sure they want them in their clinic. And the need to address that really head on is important. And then we heard earlier on that relief funding is not enough for RHC, and I think that there's still some challenges there as well. Resources that were needed are, everybody wants a clear answer. Where's the right guidance? Where are the programs that are targeted directly to clear communication with small rural primary care providers? The next thing that we sort of focused on and see in our calls is around financial viability. See some excellent work from the states around, and certainly this dials in directly to the work of the state flex programs. But I think it's fascinating how, I think it's the Colorado office in that first bullet that's monitoring facility data with a long-term approach to it, not just now, but also they plan to continue that to determine the impact of these changes and these resources and the funding that's going out, and to continue to monitor it after the public health crisis to really help identify what are the service lines that are important in maintaining and growing financial viability, and to inform their advocacy efforts. There's everything from that to really simple things like a simple letter to the CFOs with sort of a abbreviated version of things that are allowable and not allowable. I think that was on PPP expenses, or maybe it was on the SHIP funding. And then also you see a major project around identifying a gap between the state university labs and rural hospital labs and the State Office of Rural Health in Nevada has taken upon themselves to go after some RUS distance learning funds to upgrade the system and the communication and speed. So look at the things that you get into because of the crisis. Specifically noted on a variety of the calls that we really need resources for EMRs to handle advanced payments and all the coding that's appropriate for that, a tracking tool, and if somebody could come out with the right tracking tool to track all these and the appropriate use of funds without supplanting one fund, making sure that you got all the documentation lined up. If anybody can do it, the group of people on this call can, and the various funding. Of course, we got to have some guidelines in order to make that happen, to be able to write those and put together those tools, and those are a little bit slow to come. And then I think this example of financial viability and seeing the need for other grant funds and working with foundation really goes to resources that are needed for matching funds for USDA and other programs, and maybe it's time to look at those strategies around matching funds too. So another theme that we saw, and I'm trying to tear through these pretty quick because I don't really have enough time to cover all of them, was meeting the workforce needs. Definitely around so important to do some tracking of what's happening with the workforce. It sounds like a simple tool that, workers who've been tested, workers who are in quarantine and counting down. I think it was in New Hampshire they shared that they've seen a tool or there's a tool in use in their state by EMS and fire department, and under the resources needed you could see that tool could be very helpful. I think not just for hospital staff but other kinds of care providers and essential providers where we are needing to track what's happening with the workforce. I also thought all of these on here are interesting, so if I'm not calling you out, don't think that I don't respect your work and think it's worth sharing. I think that the deploying of public health professionals to rural and tribal areas is a smart strategy on some of the states. We're also seeing some of the things that we hope won't go away when the day after the crisis is over, some of the licensing and the licensing streamlining and fee waivers, and the ability to use residents and medical students and others in phone banks and pop-up driving and pop-up drive-through testing things. So we hope that those kinds of things can continue. We can see that folks can use the tracking tool. They really need staffing plans and guidelines for dealing with the surge. I think there's a lot of concern, and that was mentioned a lot on the call. Behavioral health needs. Some of this was some of the sort of the other side of it, right? We'd love to hear about in Indiana, the zero suicide training and other suicide training across the country, and it's very timely. And we know that programs and state offices of rural health who work in collaboration with their hospital associations and state rural health associations know the importance of preventing rural suicide. We heard in Montana about their effort in resiliency training, really building in a culture of society from deep within with the hospital and CHC staff and patients. And then there are certainly several initiatives on suicide prevention in agriculture and training the paraprofessionals, all of those. So it's not just the prevention of suicide. It really is about that resilience in the face of this crisis and the aftermath that could come when, quote unquote, it's over. We also heard an example of students monitoring data on rural overdoses, which have been reported to be up, and needle exchanges, which are up, which those two things going together are good. Maybe that's a silver lining to look for. I'm not sure. I think when we queried about that and talked about that on the calls, it's still kind of anecdotal because the data is not there. So the resources that were named to be needed were more tracking and data of the trends around behavioral health issues that relate to this, building awareness around staff and about the trauma from living through and being a care provider and essential worker during the pandemic. And then also we had a little comment on one of the calls about, you know, if I were a hospital CEO, and there was a lot of head nodding kind of sounds on the phone about, if I were a CEO, I'd be kind of worried about what is the aftermath when things are back to whatever the heck normal is. You know, what's it going to look like amongst your staff with those who are on the front line and those who are not? What's it going to look like among staff who are furloughed and those who are not? So I think it is about building that resilience and that team and that approach and being mindful of it now to make sure that we still have vital workforce and a healthy workforce after all this is over. The need for data has us looking at a community collaborative that's going on in New Mexico. Harvey Litt, a former employee of the New Mexico State Office of Rural Health Department, works closely with us on our policy analysis and response committee. We're going to be looking at rural primary care tools and resources on June the, I'm sorry, that's not Harvey. That is, I apologize, that's with the that's the Mental Health Tech Transfer Center that's going to help us put together that rural suicide ideation and addressing that. So we will be rolling out that little webinar. That's a little shameless plug for you. But you know, those behavioral health needs are not, certainly they've been in the news recently. We all know that that's coming. So we want to keep our eye on that as well. Those are coming up on the calls. I have found the conversation about contact tracking, which I can almost barely say, and I lump that together kind of with public health when I take a look at what state offices and flex programs and others are doing about pulling together student volunteers, state employees who are being asked to volunteer to do contact tracking. We're seeing that pretty widely reported. The use of Ohio was talking about and sharing information about leveraging social media and kind of conducting online training for volunteers, and then many of the state offices have reported that their work and the work that they've seen on recruiting volunteers for tracking, they've seen a robust tool out of ASTA, the Association of State and Territorial Health Officials, and also cited the Massachusetts model as very helpful resources. So it really is important, and we heard discussion also about how it's pretty fascinating You know, it wasn't that long ago when we used to talk about this division between public health and rural health, and it was kind of an us and them mentality, if you want. If you don't look that far back, you have to remember that, and maybe even some now. I think that's changed over the last few years, and now I think it's fascinating to hear some of the state offices talk about how now that public health is kind of called back to that core kind of public health mission, that there really is a need to support public health with those traditional public health functions, but also maybe there's a dearth or a gap in the work that's being done to help people be healthy outside of the clinic. So really support for social determinants of health, which maybe they're not able to address right now. Food is a big issue, transportation is a big issue, housing, all of those things can make a big difference. And then certainly we do want to be dialed into the data resources. And that is where Harvey is going to help us take a look at data resources for responding to COVID-19. It's kind of a listening session that we're going to talk about and look at a New Mexico model for that. So another shameless plug on my part. And then I think finally, the tribal and other populations, certainly it's been in the news a lot about what's happening on the Navajo Nation. We certainly saw it reported by state offices of rural health and flex programs way before it was in the news. But the hot spots that we're seeing on the on reservations is alarming. Town hall, some of the things that we've seen state offices of rural health be engaged in and do is conduct town hall meetings with tribal liaisons, with reservations community, ability to engage physicians in those discussions as champion leaders and respected leaders within their community. And a general approach that has served state offices of rural health well over the years, I think was in North Dakota, where their program has always been oriented to tribal elders. And so that really provides a grassroots innovation and base to build those programs from. And then also some nice innovation, I think also in Arizona, between the University of Arizona and Banner Health Systems collaborating to bring resources to rural communities. And then when we talked about the resources that are needed for addressing these issues with tribal and even other populations, it was brought up a couple times about this sense of a backlash. All Navajos are testing positive kind of thing. Or, you know, it was that one family in Winnemucca, Nevada that had a quinceañera, and it's their fault that there's a hot spot in Humboldt County, Nevada. Or, and then also there has been that kind of backlash. So it's really important to address that early on to make sure that the facts are clear. And again, that points back to the other needs for data and those kinds of things. So that's a pretty quick summary. I hope I didn't talk too long, Caleb, and I'm happy to take any questions. But I really think the hearing from John and Brock about the policy issues, we're so appreciative for that work and how it frames everything. And we hope these results are helpful to you all.
Yeah, great. Thank you very much, Terrell. And the Terrell slides are available in the file share down in the bottom left if you want to go into those with a little more depth and some time. Do we have any questions for Terrell? Star 2 will unmute your line. All right, we have one person. Thank you, Kyle. Carol, we have one comment, and that was well done. Thank you. So next we have John Suplet from the American Hospital Association, as well as Maggie Elawani from the National Rural Health Association. Star 2 will unmute your line. John, we see you there with your update. Welcome. Thank you for joining us.
Yes. Thank you very much, Caleb, and hello, Maggie. Hope you're doing well. Remember Star 2. What Caleb had invited us to do is really discuss what we see as the future of rural health post-COVID. And I think that's an important discussion and one that both Maggie and I would look forward to weighing in on. What I would like to do is frame the discussion first with discussing what we look like as rural health Medicare going into COVID, what's happening now, and then where we see that taking us as we move forward on the near term and the far term. And I do that because there's a lot of interest and subjects that have been touched upon already. What is in front of you now on your screens is a resource document, and I'm not going to go through this. What it is, it represents is a number of interventions that have taken place through the administration and Congress on behalf of rural hospitals. And Caleb, if you wanted to scroll down through that, you can see what the emergency waivers were as part of the national emergency that was declared. Some of the specifics that are for rural hospitals, some of the hospital guidance that is available on the websites, and all these links are active links. So you can use this as a reference document for your questions or interests in terms of some of these other activities. There's the legislation and the tranches of money that went forward in phases 1 through 3.5, and some of the next steps that we're advocating for. The most recent tranche of $10 billion in the rural distribution and how that took place and where it went, and in terms of that, and more specific are as an addendum on to the end of this. And then some of the legislative priorities that we're identifying moving forward as we look at the next tranche of money and the next...
This conference is no longer being recorded.
And as we look at some of the things that we've accomplished over the course of the experience of our COVID pandemic, telehealth is right at the top of that list. So that's just a reference document for you. You'll see another one is also the CMS emergency declaration blanket waivers. There was an update to that. And that would also include some critical access hospital specific blanket waivers in terms of personnel, eligibility, bed size, 3-day stay for skilled nursing. You know, the helpful resources as reference, but to the point. And the point being, where are we now and where do we see this going? Well, before we entered into COVID, it wasn't a really good landscape to begin with. And NRHA and Chartis Health have done some really good research on the vulnerability of rural hospitals in general, community hospitals in specific. And the University of North Carolina came out with a study today that was identifying days cash on hand for rural hospitals. And the interesting thing is that critical access hospitals have, on average, 72 days cash on hand, which doesn't sound like a lot because it's not, but it's a whole lot better than any other category of rural health care, rural hospital provider. And that speaks volumes to the overall situation of rural health hospitals' financial viability heading into COVID-19. Maggie, you want to comment on that? Remember, you're on mute, Maggie. Start to on your phone.
Admitted COVID-positive patients, but a true surge. The trauma is extraordinary. The trauma to the staff.
Ayla, can you hear?
This conference will now be recorded.
The community is exceptional.
I can hear you, John. I cannot hear Maggie.
It has surfaced in some aspects.
Oh, okay, I know. I'm sorry. Okay, that's fine.
As we look through the near term,
You can always text your comment into the chat box too. So as Maggie's trying to get, to figure out her link for audio, again, we've seen the iVantage numbers, we've seen the vulnerable hospital numbers from both Chartis and UNC, and we know going into this that we were in a bad situation that only COVID would make worse. So I'm going to talk about both the negative and the positive of our experience to date with COVID in rural hospitals. And I'm going to start with the negative. And the first negative that has been an experience that we all share, and Carol and others have just touched upon, is trauma. And for those rural communities who have suffered through a surge, not just having admitted COVID-positive patients, but a true surge, the trauma is extraordinary. The trauma to the staff, the trauma to the caregivers, the trauma to the community is exceptional. And it has surfaced in some aspects immediately. But I think as we look through the near term and even through the next year, there will be elements of this trauma that will continue to emerge that have to be addressed locally. And it's the sleeping giant. It's a bubbling cauldron, and it's something that we have to keep remain vigilant to, so that we can address it when it is important in our community. I think that oh, sorry, I can't hear you. No, but interestingly, we can read you. So you are being transcribed in the box. I'm not sure she's unmuted, Kayla. Maybe you can check that.
Yeah, I know we're working.
I'm going to see if you can hear me now.
So trauma being one of the negatives. The next and most obvious negative is lost revenue. It will be very difficult for rural hospitals to recover the revenue that was lost as a result of having to eliminate elective services. And this is across all providers. Whether you were part of a surge, whether you admitted COVID patients, or whether you did not. The reality was that the governors had made orders in almost every state as to shelter in place and to eliminate elective services as a result of COVID in order to manage the surge and to compress the experience. Well, that lost revenue is going to be very difficult to recover, as will the volume that came with the revenue as a result of the changes in practice patterns. The emergency funding and the advanced payment, paycheck payments, and the accelerated and advanced payments through the MAC, those loans were very helpful with getting the bills paid. It brings some stability to hospitals and their operations on the income side, but it does nothing on the balance sheet. That is, while it will help provide money to pay the bills, to meet the loan obligations, to meet any other financial commitments that are out there, it will not help them build their reserves. It won't help them recover lost services or revenue. And for that reason, it serves the purpose of keeping the hospitals viable for the near term, but it doesn't address that issue that we were confronted with moving into COVID, which has only been made worse as a result of the experiences that hospitals have had. So that's a very difficult conversation that will continue to be part of us moving forward. And then the third issue I would say is a negative is workforce. And there's been a lot of adjustments made locally to the workforce, either through furloughs, reassigning of staff, and reuse of staff. And for those communities that have, and hospitals that have suffered furloughs or layoffs as a result of COVID, their COVID experience, that's also going to prove to be a challenge moving forward in the near term as well, as they try to recover those staff members based upon the ability and the business that's at hand. So those were the negatives. On the positive side of the COVID, Maggie, just weigh in when you get a chance. On the positive side, that we've seen is the tremendous expansion of telehealth and the new access points that are being created as a result of telehealth. Someone also referenced this earlier, but I think it's extremely important. It's the advanced practice clinicians now practicing at the top of their license has also increased access points for primary care and specialty. And so that is a huge plus as a result of this. The expanded broadband and the money that's been invested in broadband and that will bring Wi-Fi and telehealth and other telecommunications to the 6 million rural residents who really don't have it now is a huge plus. The loan deferment programs, either through USDA or HUD, that has happened as a result of this is important. And as are the various administrative and regulatory waivers, which you can reference on those documents that are attached, have been hugely important. And they speak to where we may be going next. What might be the next steps? Where will this momentum carry us moving forward as we look to the future? And so that, I'll pause there because one of the things that is consistent throughout all of this past, present, and future is testing. And so much of our ability to move forward for the next steps of resuming services is contingent upon our ability to test with confidence. And as we speak, and I'm sure it's true for Maggie as well, as we speak to the hospitals that are out there who are in a state where it is looking at reopening and resuming their services, testing is probably their single biggest limitation, that they don't really have the resources to do it. They don't have the confidence in the testing that's out there. And they need to be able to assure the safety of the patients and the staff before they can resume some of these elective services. So that, again, is a continuing theme that we'll be looking at moving forward. The other interesting phenomenon is in those states that have already reopened, and that would include Missouri and New York and perhaps some others that you may be aware of. Those states that have reopened some of their elective services are getting testing done in a pretty expeditious manner, 24 to 48 hours, which is terrific. But the interesting point is that as more hospitals come online to more states, how well can Quest and LabCorp meet the demand for testing that's going to come forward as a result of this? So considerations, again, moving forward. The other thing that was pointed out to me today in a conversation is how we had repurposed and reassigned staff from their clinical obligations, whether they were in a clinic or in a specialty, whose services had been postponed, and now that they're moving back to their assigned duties in surgery or the clinic or some other department, that leaves the void for the positions that they filled. So the extensive cleaning, the greeters, the other support service activities that were taking place to which they were assigned now have to be filled. So those jobs remain empty, and interestingly enough, hospitals are recruiting to fill those positions, which means you have yet another expense. Those expenses didn't go away just because we're reopening and resuming services. And in fact, they remain as long as we're under the emergency for COVID in whatever phase we are in a particular state. So then I'll just finish by referencing volume. Physician independent physicians have really had a struggle through this experience.
I think my speaker may work now. Can you guys
hear me? And the relationship that will exist between independent physicians in the communities and the hospitals themselves, and how those will be resolved moving forward is an issue. It raises the questions of continued mergers, acquisitions, and affiliations.
But you guys can't.
With those hospitals that have those mergers and acquisitions and affiliations having more resources than the independent hospitals.
I'm using my computer. I did call in, and that didn't seem to work. At the same time, I've got 3 kids that were on the internet, so my internet kept going out. So I apologize for that. I
make them meet in the near future.
But you can hear me, Sally?
And all of which then begins to speak to the larger picture of new models of
I
payment
was just
and
patting
delivery,
myself on the back on
and
how what a
what
pro
that
I've
means moving
become on
forward, and the
Zoom and
extent to which we
Google,
can
but
guarantee
Adobe's
a
new to me,
medical
so I'm
presence
sorry.
in the
I think I
communities
have
that
who
have
can hear me? Raise your hand.
really suffered the greatest as a result of the COVID
Only Sally.
pandemic. And I'll
Crap.
stop there.
I did have a couple of things I wanted to
sorry,
add
Maggie,
on to what
we
John's
didn't
saying.
get to
Should I
hear
call
from you
into
because I
the
know
line?
you would have been helping me quite a bit with this explanation of next steps. But Caleb, that's where I'll stop for now.
Okay. Do you want me to continue, or is it not worth it? I just wanted to say a couple of things.
I think my speaker may work now. You guys can hear me. I can't hear you.
So it's been hell these last 8 weeks for rural
yes,
providers. They've been bleeding cash. We feel pretty good about getting a... Okay.
Maggie, did
Sorry.
you call into the
really...
phone number? That might...
Okay.
Okay.
I've been there.
Yeah.
Yep.
Thank you. And again, my apologies. I will be brief. I wanted to point out a couple of things.
Yeah,
NRHA and others worked very hard on getting the rural carve-out of $10 billion. There is still money
in the
HHS provider fund.
I think we can hear you through the computer, but not the phone line.
Pressure on HHS. There's a letter being sent by Senator Manchin and Senator Murkowski. We're just starting a sign-on letter to get another rural carve-out for the remaining amount of funds, which is significant. The other thing that I wanted to point out is that for the last 2 days we've been doing a series of calls with the Small Business Administration regarding the PPP
I like that idea.
fund.
That way we can at least
There
get
is
it
still
and
money
send it
out there.
note.
There is still
Might
significant
not be
money
ideal,
out
but
there.
we do
They
absolutely
really want to
hear
make
from you,
sure
Maggie.
it gets to rural healthcare
benefit to have you
providers.
on the call. So
And I
please,
am worried that there's been a bit of
there's a bunch of people who can hear
misinformation
you
on the
or hearing you
ground
audibly, and those
about
of us
this
who can't, we
program.
can read the transcription. So please,
It really is designed for a lot of healthcare providers, especially small business healthcare providers. We want to make it work. The administration wants to make it work for rural healthcare providers. It would be a shame if anyone missed out on this opportunity. It really is pretty much 8 weeks of loan forgiveness where you can pay your employees, you can pay your utilities, you can pay your mortgage. We think this will be an excellent tool for rural providers because just as John said, the money that we have so far is finite. It is limited. We need to figure out now a longer term stabilization. We need to make the temporary pay cuts like sequestration and reimbursement for telehealth permanent, but we need to figure out long-term solutions for rural healthcare. And we're just sending a letter today to Congress, and I'll share it with folks on what we're asking for a long-term fix. But again, I am sorry about this, and please forgive my stupidity on technology. I would just like to. Didn't hear all of that. Did you, John? see it. Mhm.
No, you're fine, Maggie.
Thank you. We do appreciate your patience and willingness to participate. Do we have any questions for Maggie or John from the Hospital Association, from National Rural Health Association?
The one thing I would add is that I know there's a lot of concern about.
Is there any movement on reimbursement for patient in
I think there's going to be a lot of concerns
prior
about
to and after a procedure?
About how to organize the money that you're getting, be it from the PPP, a HRSA grant, or the provider fund.
Yeah, I have to,
and I know there's a lot of anxiety
my
out there about that and potential repayment of provisions.
That's the tricky part. Is you
John
get the
and I
echo
know
when the
AHA is
laptop's on.
working really hard. We're working hard to try to
specific, and
make
you can
sure
read the question in the chat box
that
too,
all
Maggie.
rural providers are treated fairly. We have a meeting with
targeting
SEMA
of
Verma
patients that are
on
in
Friday to
isolation prior
discuss
to
this.
or after. Assuming
So
that
I just want
this is
to
a Medicare
ease everybody's
patient, they would still be
anxiety,
covered under
and these
Medicare
programs are so limited.
for
We're
the
hearing of
reason they were
hospitals
admitted,
that are
whatever the
actually
diagnosis,
turning away
the
dollars
related
because
group
they're
they were
worried
admitted,
about it. I
and
hate to see
if it's
that
critical
happen.
access
I
hospital, they
really
would
think
still
we
be
can
covered
win the
under Medicare.
long-term
So there's
fight
nothing
of making sure this
specific with
comes
any
out right on cost
movement on
reports.
reimbursement for
So
patients
don't
in
turn away
hospital
resources
isolation.
that you need.
Thank you, John.
Right.
Any other questions? Oh, sorry, I'm interrupting.
A lot of concern.
Absolutely. I think everybody wants to encourage you to make sure you are keeping track of where this money is going, of what it's being used for, of what you are receiving. But again, if you need it, don't turn it away. We have a good ear in Congress and with the administration on how challenging things are in rural America and in rural healthcare. I think we're going to win these long-term fights on getting this cost report stuff all worked out. So don't keep records, but don't turn it away if you need it.
I'll add another heads up, Maggie, that you can comment on, because Brock brought it up in our conversations yesterday, and that is attestation. And the requirements and the terms and conditions for these various loans, whether it's the advanced payment program through Medicare and the MAC, or the paycheck payment program, is the ability to attest to the fact that you are using the money properly and the eligibility for that. And that will be some record keeping that all hospitals, including critical access hospitals, have to adhere to moving forward.
Great. Thank you very much, guys. Any other questions? Otherwise, Jack, are you there from Montana or other state flex programs? Now we would really like to hear from some state flex programs to hear what changes have been made to work plans or just operations supporting their hospitals out there. How's your audio, Jack?
Caleb, I just unmuted. Can you hear me?
I can hear you. Welcome. Thank you for joining us.
Well, I wonder if anybody else can, but anyway, yeah, and I'll be brief because I know you're over time, but so I'm going to share what was the coolest thing that happened, and it was just it just bubbled up as so many things these days are doing. But I want to thank Terrell for mentioning the on the NOSOR call about the Montana resiliency work that we did with the state office here in Bozeman. They approached us having found the source of that resiliency program, and we collaborated with them to get it presented out to our critical access hospitals. And we're looking to put together another cohort here in the future. But the coolest thing that happened, and I don't know how many of you know this, but Montana is, luckily, fortunately, has not suffered as deeply as so many other parts of the country. Although in the ramp up, there was no belief that we wouldn't be hit as hard as everybody else was. And so as we anticipated, the first cases showing up in Montana, they ultimately did. And one of the very earliest was up in Cutbank, up in Glacier County, the northeast end of the...
The organizer has disconnected, and this conference will continue for 60 minutes.
Okay. It's up in the northwest corner of the state, and so they received one of the very first positive COVID patients, and also had one of the first deaths, if not the first death. But previously to the arrival of COVID, we had began a project with a PharmD, a clinical pharmacist up in that little critical access hospital, to provide some services, consulting services to other critical access hospitals that were struggling to implement ABS programs. And we had actually gotten ready to get started with her in a couple of hospitals in the eastern side of the state, and of course got suspended by COVID. As all of our other projects have been suspended as well for the most part. But she reached out, and so we worked out a deal that she was interested. She thought that she needed to share their experience in Cutbank with other critical access hospitals in advance of receiving, an actual positive COVID patient. And even though the patient died, it wasn't due to anything other than the disease. But in the course of that, she referenced that they threw the kitchen sink at her, and so she wanted to consult with other pharmacists on what drugs to have on hand, since there is no therapy, how much of these drugs to have on hand, certain things about how to actually deal with a positive COVID patient. And we, out of our 48 critical access hospitals, we had 17 or 18 that reached out to her and consulted with her, and we were able to help reimburse that critical access hospital for her services. And that was just really cool the way that came about. But I don't want to dominate for other programs. I'd love to hear what other people are doing, because I agree with everybody on this call today. Nobody has a real idea what this is going to look like, but we are going to have an awful lot of work to do.
Yeah, agreed. Thank you, Jack. Thank you for sharing that. So we extended the length of today's webinar. Sorry if that wasn't clear to everyone beforehand, but we knew this was going to be a popular topic, and that there were a bunch of updates, and we wanted to leave plenty of time for state sharing. Sorry, I stumbled over that. So yeah, I would love to hear what other states are hearing from their hospitals, any other efforts from the state flex programs. What are we heard from Terrell what a bunch of state state offices are talking about it. How are you guys finding your hospitals and the response? *2 will unmute your line if you're dialed in. Or please feel free to type in the chat box. I know we've heard initially, it was a few weeks ago, just how busy the hospitals were. So there wasn't a whole lot of requests other than waiver information that I was hearing about. couple people typing in the chat box.
Hey, this is Stephanie Nance from North Carolina.
Hey, Stephanie.
How are you?
I am well. How are you today?
We're doing great. So just wanted to, we haven't fleshed out all the details about this, but I'm really excited about North Carolina and their efforts to increase payment for swing beds for critical access hospitals during this time. We don't have the details yet, but we've been in a lot of discussions about that, and as soon as we know something, we'll share, because that's a model that can help across multiple states. You know, if I always say if you pay for it, they'll come. And, you know, even if critical access hospitals, not all of them in North Carolina are in the position to treat COVID-positive patients well because they don't have ventilators and so forth on supply, but they could take non-COVID patients to free up the beds at the larger facilities. So just wanted to give a shout out about that work in progress.
Great, thank you very much. Laura writes that in Illinois we have just gotten permission to start elective procedures on May 11th. They are anxious to start doing these procedures and bringing people back into the hospital. Yeah, I know my mother works in a hospital back in Colorado, and she was saying the same thing, that they were starting to plan elective procedures for, I believe it was this week as well. Jen Edwards from the Pennsylvania office has been working diligently on sending out COVID-19 updates regarding funding, cybersecurity, and a variety of other important information. All of the hospitals have indicated that her updates have been extremely helpful. Thank you, Lynette. That's really good. And those are great examples of the types of information and updates that your hospitals might be looking for. Any other comments, questions?
Caleb,
questions
can you hear
that you guys are getting? I can.
Hey, it's Kyle. So
Hey, Kyle.
if we can, hi, it's good to see all you guys. So in Wyoming, we have started procedures. Those actually started a week ago for a lot of our hospitals. And one of the things I think that we as a FLEX program were able to do was give them the resources they needed to figure out how they were going to write those policies or what that looked like. We had, thanks to Rochelle Spinarski, she hosted biweekly calls with both our financial offices and our quality improvement so that we could walk through them with those things. And I think it's been really beneficial. We've been able to hear from them. One of the things that we identified right away, or almost right away, was obviously telehealth, but then tying that into our FLEX program. And so then what can we do to make help with quality improvement around telehealth? And then identifying that data element. So we do the consumer assessment of healthcare providers and systems. And so one of the things that we talked about is, can we develop a telehealth cap so that we can also find out how our customers are, how their experience of telehealth is and what we can do to improve that. But the thing that weighs, there's a couple things that weigh heavy on me. I really appreciate Carol talking about behavioral health and the suicide prevention and how absolutely essential that is in this time. And so I think that's something that I appreciate hearing about and something definitely to move forward with. But when we talk about operations in the FLEX program, how do we help those hospitals, which we already know, as we've talked about, are furloughing employees, but also maybe renegotiating provider contracts. A lot of our providers are on contract. Those obviously got negotiated way before COVID-19 came into existence, and now here we are. And so what does renegotiating contracts with our providers look like, and then what does that do as far as the systematic problems that we have going back to housing and having affordable rents and affordable mortgages? If we're going to, in order to be financially viable and remain sustainable, if we have to renegotiate those contracts and those providers and those healthcare workers are going to agree to take a less salary for an extended period of time, what else can we do then to help them with their mortgages and rents? And so that's something that weighs heavy on my mind. I'm afraid to look at the unemployment numbers. but I think I have to. So, and I want to thank everyone who presented information today. This was so beneficial to have real resources on what we can do moving forward, because it's helpful. It seems like we're in the dark tunnel and the light is out there, but it's just a pinprick. So I appreciate everyone today.
Great, thank you very much, Kyle. Yeah, I think that's a similar situation for a lot of people. I know hospitals are having a real hard time considering and thinking about that. A reminder that all of the presentations that we have today, as well as John's resource page, as well as other resources, are available down in the file share box. We will make a collection of the meeting minutes from today's webinar, so we can do our best that everyone can hear Maggie and at least get the information. You know, Aaron with his EMS update gave a bunch of updates and information on stuff, but we'll pick that stuff out and provide links to those resources. Rochelle Spinarski says that in California, we meet semi-weekly with QI teams to share promising practices, policies and procedures, how to acquire and monitor PPE, testing issues, communicating with community members, etc. That's a great process there, Rochelle. I think that's really cool. Rochelle says in Wyoming, we also added critical access hospital COVID-19 specific info to our website. Thank you. I think that's really helpful information as well, at least where to find resources and updates. A couple other updates. The virtual knowledge group calls for TASC will, the next one is scheduled for, I lost my paper, for July 27th on systems thinking and frameworks. Look for more information on that as it gets a little sooner. We talked about the federal office extending the NCC deadline. And we here at TASC are extending our offer deadline to help review and provide feedback on one of those NCC items. We will accept, I get requests for review through January 1st, and we get those back to you with feedback from a couple TASC members within 1 working week, 5 business days. Thank you to the Flex Workshop participants for your flexibility. With the Flex Workshop, I guess it was close to a month ago now, we held our first virtual Flex Workshop, and it went well, and we really do appreciate your guys' patience and understanding with that. And as a reminder, we did send out a notice and update an email about the reverse site visit being moved to a virtual site visit. So more information to come on that, but please do hold those dates of August 5th and 6th on your calendar, as we intend to use those for some of the presentations. Let's see if we got some more questions or comments in the chat box. Tricia says that Alaska has had really strong direct involvement between our rural hospitals and our state EOC on support federally. Focus has been on ramping up capacity for testing, distributing PPE, establishing alternative care sites, and maintaining the low case count and number of deaths. The current concerns are preventing hotspots as fisheries workers enter our coastal communities and vulnerable tribal communities. Thank you, Tricia. Jill said that in Arizona we've been having weekly COVID hours. Is that through your office, like an open door forum where they call and ask questions, or just discuss what's going on with the hospitals, Jill? Laura Fisher says that twice a week calls the CEOs to discuss all things COVID. Also calls with individual department managers so they can ask their peers what they're doing. I think these are all great examples of cohorts and best practice sharing and just communication, if nothing else. If I don't have to make a template to post a notice to my community because Tracy already has one and I can just get it, that one little bit does help because that's less staff time needed to make things. And it's, you know, discussing those messaging that you wouldn't necessarily think about on your own, but because Tracy already thought of it, then Sally doesn't have to think of it herself and can benefit from Tracy and my experience in that. So I think these are all great examples. Jeff says that Michigan also added a critical access hospital COVID-19 specific info to our website. Thank you. And Jill is typing in, I assume, some of the details of her calls. So we have a presentation based on what hospitals want more information on. We had a great call today on setting up COVID units. Thank you, Jill. I think those are all great examples of what things are happening and what can be done. And then from those, you're able to identify opportunities that your office can work on. What other questions do we have? I believe those are all of the TASC updates. I think we're getting out a little early, which is good. I would like to thank all of our presenters and speakers and participants from Maggie to Carol. Let me make sure I get everyone so I don't just try to run through them all through my head. Jack and other state flex programs for sharing what they're up to, what they're doing, how they're going about it. John Suplet from the American Hospital Association, Maggie Elawani from the National Rural Health Association, Carol Eisinger from NOSOR, Nathan Bao from the National Association of Rural Health Clinics, Megan Lahr from the University of Minnesota and the Flex Monitoring Team, Sarah Brinkman from Arcata and Stratus Health, Aaron Reinhardt from the American Ambulance Association, Gary Conejo from the Federal Office of Rural Health Policy, as well as Tori Leach from the Federal Office of Rural Health Policy. Thank you all for presenting and helping us formulate our conversation and identify hopefully some resources and some support that we can provide here at TASC and also for you guys at the hospitals. Jill says small hospitals are really struggling with the amount of space they have to isolate COVID patients. Yeah, I can absolutely understand that. In reference to the hospital my mother works at, she said they took over a whole like waiting room area of the hospital and made that just specifically to COVID patients. So it was, you know, an area that with